I'd like to welcome everyone to our webinar today. I'm Linda Baker, the Learning Director at the Center for Research and Education on Violence Against Women and Children. And we're delighted today to bring you from the Knowledge Hub and the Learning Network our webinar on From Trauma-Informed to Trauma and Violence-Informed. And we had 454 people register for this webinar, and I think it speaks, one, to the distinguished reputation of our guest presenter, as well as the importance of this topic to our work. Dr.Colleen Varcoe is actually joining us from Geneva, Switzerland today, and that's pretty special, and I must say a first for our center. Dr. Varcoe, for those of you who don't know her, is a professor in the University of British Columbia School of Nursing, where her research program aims to promote ethical practice and policy in the context of violence and inequity. She has published many peer-reviewed publications and also co-edited a book. And currently, she's co-leader of a team conducting a longitudinal study of the health and economic effects of violence against women after women have left abusive partners, of a study examining the delivery of primary health care at urban Aboriginal health clinics, and a study of Aboriginal women's experiences of leaving an abusive partner. Our format for the webinar today is to hear from Dr. Varcoe for 1 hour, and during that presentation, if you would just write any comments or questions that you may have for Dr. Varcoe in the chat box to the left of your screen, then during the last 15 minutes of our time together from 2 to 2:15, then we'll present some of your questions to Dr. Varcoe for her response. We'd also just like to let you know that occasionally Dr. Varcoe's voice may disappear, but she didn't leave us. It's just a connection, and the voice quality when she returns for just a couple of seconds may sound high-pitched and rapid as the internet connection catches up to the real-time presentation that is occurring. So with that, I'm very happy to turn it over to Dr. Varcoe, who's going to present our webinar. Dr. Varcoe, I'm just going to ask you to click your microphone, the talk button, so that we can all hear you, and I'll turn mine off.
Oh my goodness, okay. I was asked to ask if people could hear me, if they could type yes into the chat box. Yes, yay, okay, thank you everybody. That's great. Greatly appreciated. Okay, well, thank you very much, Linda. And Linda, I actually think that the high levels of registration actually speak to the hard work and the effectiveness of the Knowledge Hub, so congratulations. And good evening, good morning, good afternoon to everybody, depending on where you are. I think it's really exciting that we have so many people from so many different sectors. I know we have people from corrections, child and youth, the healthcare sector, and much more, victim services, the shelter sector. So I'm going to be speaking primarily from my experience within the healthcare system, but I have hopes that it's going to be of use to you. So I'm hoping that you're all seeing my slides by now. And I'm going to just tell you a little bit about what I'm hoping we can accomplish in the next hour and 15 minutes. So my goal is to, as advertised, talk about the idea of trauma and violence-informed practice. And I'm hoping that this is going to help assist you to extend and integrate your understanding even more fully. All of you will be at a different place with these ideas. And really in particular to integrate the idea of violence-informed in addition to trauma-informed care. So I also hope that we'll end with some practical approaches regarding how to integrate these ideas and also the notion of structural competence in care. So I thought that I'd tell you a little bit about what I'm bringing to this and why I've arrived at this idea of trauma and violence-informed care. I started my research in about 20 years ago, actually, focusing on the question of why it was that emergency nurses weren't effective in responding to violence against women. And I was an emergency nurse myself, and I was deeply concerned about that. And the answers to that led me to looking at the broader systems, and I, at the request of service providers, began a project with women who themselves had experienced violence to look at their experiences with the intersecting systems, not just justice and the shelter sector, but the healthcare system as well. So this increasingly drew my attention to the broader context of women's lives, and I was invited to do some research on the intersections between the risks of violence and HIV, particularly for women living in rural contexts and Aboriginal women. So I kept drawing on these experiences and focusing on our social responses to violence against women, with particular attention to the healthcare system. And I did another project on maternity care, and you think, well, maybe that doesn't have as much to do with violence against women. But as I think you'll see as I kind of move forward, violence, and in particular structural violence, which I'll talk about a bit, was always operating in the experiences of women and their efforts to access maternity care. And so I think that it sort of broadened my scope to work in a rural context with Indigenous communities. It helped me sort of pay attention to the broader conditions of women's lives, which sort of underscores for me the importance of attending not just to individual experiences of violence, but the larger structures that shape people's lives. My team and I have done quite a bit of study on the health effects of violence. So we looked at, over time, what are the impacts of actually leaving an abusive partner? Does women's health get better? And using that as a basis for hopefully designing some interventions to enhance women's health and well-being. So just a couple more studies, and this next one is important because we started looking at, well, how do primary care settings provide good care to people who have experienced violence? And this was really helpful to us in sort of looking at what's needed within the healthcare system, because that's been one of my big goals, is really to try and enhance the healthcare system response to violence. So the last three studies that I'll just tell you about are the ones that I'm currently working on. So based on all of this work, I've worked with a number of researchers to try and develop some interventions to help improve women's health after they've experienced violence, and we've just completed a study of an intervention with Indigenous women, and I have to tell you, I'm very pleased that we really have had some very positive effects working in collaboration with women. We're also just, we haven't finished the study, but we're just testing whether or not an online safety and health resource can support women and complement what the community domestic violence services and shelter sector can provide to women, and see if online support can also be useful to women. And finally, we've just finished up a study, again, looking at how is care provided within primary care. And this is important because we see equity-oriented care, which is what we're testing, as being a combination of cultural safety, tailoring to the context that people live in, and no surprise, trauma and violence-informed care. So we're testing whether or not we can improve care in the broader healthcare system by focusing on those areas, including, really importantly, this idea of trauma and violence-informed care. And our next step is to try and we're partnering with emergency units to see if we can improve care, particularly for Indigenous and non-Indigenous people in emergency departments, by harnessing this idea of trauma and violence-informed care that I'm just going to tell you about. So this is the slide that you're seeing now shows you that I see, or our team sees, trauma and violence-informed care as a real central component of addressing equity in healthcare. And we think that that always goes along with tailoring to the context, aiming for culturally safe care, and also using a harm reduction lens. So we've been working on these interventions to work with organizations to try to improve how things are delivered. And I think my point is that trauma and violence-informed care isn't provided in a vacuum. It has to be provided within organizations that are oriented to equity and oriented to these ideas. And I'm really excited that the next seminar, I think it's in January, the next webinar, sorry, is really going to look at what it takes to be a trauma-informed organization. So I think that'll be very helpful to us as well. Okay, so on to the idea of trauma and violence-informed practice. This is building on what many people will be much more familiar with, which is the notion of trauma-informed practice. I'm trying to integrate this idea of trauma and violence-informed care because I want to draw attention to a range of things. First of all, that violence is often ongoing, and sometimes in the literature and in practice and in policy, when we focus just on trauma-informed practice, we overlook the fact that people are living with violence, and this can be at an interpersonal level or at a structural level. So the idea of trauma and violence-informed care helps us make sure that when we're talking about trauma-informed practice, we're not just talking about what's going on historically for people or what is going on in their psyches, but rather look at the conditions of people's lives so that violence can be both historical and ongoing, and it's structural as well as interpersonal. So I'm sort of continuously trying to draw attention to how interpersonal violence is continuous with broader structural violence. So just to give a very simple example, gender-based violence is continuous with gender inequity. So I just want to mention this idea of structural violence. Many of you will be quite familiar with it. For some of you, that might be a newer idea. So when I'm talking about structural violence, talking about the various forms, the various ways in which society is structured that creates harm, inequities that are embedded in how our society is arranged that actually cause serious harm to people. So extreme poverty and relative poverty, racism, and not just racism at an interpersonal level, but structural racism, so that people can't find places to rent, or they can't get jobs, and so on. So Paul Farmer is a physician that's done a lot of work on this idea of structural violence, and I think it's very useful to draw attention to social inequities that are at the heart of structural violence. So I think that this draws our attention when we are service providers to the simultaneous importance of how things are structured, to policies, to how we organize our services, and so on. And I think the closer that people are to the reality of those we serve to their lives, I think the less we can ignore the fact that the conditions of people's lives determine the ways in which they can deal with the violence they experience. So as a nurse working in an intensive care unit, I'm very, very far removed from the reality of people's lives, whereas if I'm working in a community, it's much more front and center for me. So I think that the notion of structural violence helps us pay attention to political and economic organization of the world, and how inequities are part and parcel of how people are able to deal with and limit the effects of violence in their lives. So as I mentioned, I think that it's very useful to simultaneously pay attention to interpersonal violence, that is between people, and the structures within which people live. So I've just given a couple of examples. We often focus on homelessness at an individual level, but as we probably all know, homelessness has to be addressed at a structural level. What causes homelessness isn't poor mental health, but rather the structures, poverty, social support levels, and so on. So moving from that idea of structural violence, the idea of trauma and violence-informed care shifts how we think about violence. And in some sectors, particularly I would say in healthcare, we think about violence as an individual problem. And we're thinking that there are actual identifiable victims and perpetrators, and that those are clearly delineated. Whereas as many of us will know, violence is a big social problem, and it's not just about individuals, and there's no hard line between victims and perpetrators. There isn't sort of a dichotomized identity. But the other idea that I'm hoping that the ideas of trauma and violence-informed care push back on is the idea that people have choices, and that those choices are unfettered, and that people have unlimited agency. So I think that one of the ideas of looking at the structures and the conditions of people's lives is to pay attention to how people's choices are seriously constrained by their circumstances. And I think that when you look at violence in this way, and many of you already do, it really keeps the focus on individuals, but it helps us go beyond that focus, and helps us to look for the patterns, the gendered patterns, the patterns of racism and classism, and how those really affect how people's lives are shaped and their experiences of violence. So the argument that I'm sort of putting in front of people is that given how much violence pervades our society, we ought to be treating people everywhere in a trauma and violence-informed approach. And we've had in healthcare some fairly simple responses, the idea of screening for violence. And we know that there isn't really a positive benefit to that. We're pretty sure that there aren't harms to it, but there's no shown benefit. So what I think we're moving toward is a more universal precautions approach to trauma and violence-informed care. That is, treating everybody as though they may have a history of violence, and there may be ongoing violence in their lives, and that they may be experiencing conditions that make it very difficult for them to deal with interpersonal violence as well. And when we turn our attention to racism, discrimination, poverty, structural organization, it helps us really reinforce on the importance of a non-judgmental approach. And as those who've worked in the community domestic violence sector and shelter sectors know, the importance of avoiding disempowering. And in healthcare in particular, we've focused a lot on getting people to disclose when they have a history of violence, when they're experiencing violence. But when we're talking about trauma and violence-informed care as a universal approach, it means that we can be safe and provide good, high-quality care regardless of whether or not we get a disclosure. And paradoxically, it's interesting that when you practice in this way, you build a lot of trust, and you get, I think, a much higher rate of disclosures than even when you're starting out with asking direct questions. So the theoretical foundations of the idea of trauma and violence-informed care, first of all, builds importantly on trauma theory and the idea of trauma-informed care, which has been around for a while. And the goal of trauma-informed care is aimed at the organization. So what we're trying to do in trauma-informed care is create organizations that have a high level of awareness of trauma, emphasize safety in building trust, and fostering choice, collaboration, and really taking a strengths-based approach. Those are all the key ideas behind trauma-informed care. Adding to that is a critical perspective on interpersonal violence. So paying attention to gendered violence and the effects that are ongoing, and how interpersonal violence has ongoing and cumulative effects. So often, certainly in healthcare, we tend to deal, and I think to some extent the criminal justice system is set up to deal with single acts of violence or single instances of violence. And yet we know that the effects and the impacts are cumulative over a lifespan. So adding to that then is this idea of cultural safety. And in part, this is addressing the fact that we are dealing with multiple forms of violence simultaneously, and particularly drawing attention to the role of racism and discrimination. So cultural safety and structural competence helps us pay attention also at the organizational level to what are the policies and practices that can address power relations, discrimination, and the impacts of historical and ongoing forms of violence. And finally, as I've already mentioned, the idea of structural violence, so that we respond to individuals, but understanding that the individual experiences are occurring within the backdrop of disadvantage that is supported or can be supported by unfair policies and institutional practices. So drawing attention to our practices, not just with individuals, but a broader level. So I apologize that I just feel like I'm talking at you all, but apparently that's the format of a webinar. So I hope you're all still with me. Okay, so I'm imagining that most of you could think about, would have a pretty good working definition of trauma, but I just wanted to point out that trauma has long been identified as including stigmatization related to gender, race, poverty, and so on. And I also wanted to point out that it is a bit of a problem that we use trauma to mean both events and the responses to those events. And I think that's just something that I think is worth acknowledging, because sometimes we're a bit unclear about, when we're talking about trauma, whether we're talking about the impact on an individual or the events that they've experienced. So I think that over and over again we use it to mean both things, and I think it's just important to acknowledge that. So I'm just reiterating here why I'm trying to add in the idea of violence to trauma-informed practice or trauma-informed care. And I've highlighted in red what it would add. So it's not just attention to violence, but attention to the fact that violence could be historical, but it can also be ongoing. And in the work that we've been doing with, most recently with Indigenous women that have experienced intimate partner violence, it's really crucial to recognize that some of the biggest barriers to their well-being is the fact that they're dealing with racism on a daily basis, or they may in fact be dealing with the impact of a history of being in foster care and experience high levels of violence in that experience, and at the same time partner violence and dealing with ongoing racism in their everyday lives. So this, as I previously said, helps us sort of not just locate the problem of trauma in a person's psyche, but also the ongoing conditions that people are living. The other thing is that it really, when we're thinking about structural violence, then it helps us to draw attention to the intersections among multiple issues. And in healthcare, I think it's absolutely crucial that when we see somebody who has a problem with substance use or they have chronic pain, that we're automatically thinking about a history of violence and also the conditions of people's lives. So I think that we don't just want to pathologize people and take it all down to a biomedical, physiological level, but I think that particularly in healthcare, when we pay attention to trauma and violence at the same time, it helps us pay attention to what the physiological consequences of these intersecting issues are. So, for example, there are very high levels of arthritis among Indigenous people, and we have to attend to the fact that this is the outcome of a whole bunch of intersecting forces, including histories of trauma and living in poverty and so on. Not that all Indigenous people live in poverty by any stretch, but when we're providing services to people who are presenting with various health issues, then really paying attention to the conditions that give rise to those health problems and also sustain them and make getting support difficult. In particular, I'm really interested in how we deal with pain. And often in the healthcare system, we're dealing with pain as though it can be disassociated from people's histories of violence. But we know that violence and abuse and other forms of stress, such as racism and poverty, have direct physiological effects that change people's ability to manage their pain. And then, of course, unresolved pain is associated with substance use, but within the healthcare system, we're often just dealing with people's substance use issues without any way of addressing their histories of trauma or the ongoing violence that they're experiencing in their lives. So I'm hoping that the idea of really integrating attention to violence, particularly structural violence, with our attention to trauma is going to help us have a much more comprehensive approach across all our systems. So really linking structural violence, health equity, and the social determinants of health, so that when we encounter individuals, whether they're presenting with a health problem such as diabetes or substance use, or they're not presenting with a health issue, but they have health issues operating in the background, that we're linking all these ideas together. So what what this all would say in practice is that any person we encounter across any of our systems may have a history of interpersonal violence or may currently be experiencing interpersonal violence. And we don't always require a disclosure to provide safe care. Often what people are presenting for service with, the issues they're presenting with, are not necessarily directly related to violence. And yet, if we're trauma and violence informed, then we're going to be able to build trust that's going to provide safe care. I also think that it draws our attention to the fact that often when people have experienced violence or any other stigmatizing condition, they're going to anticipate that they might be judged. So that it's incumbent on us as service providers to create optimal safety for people. Another key idea is, and I think we see this over and over again, that people don't underestimate risks and danger, but they don't overestimate danger or risk, but they may underestimate. So it helps us as service providers to really support people in being more realistic about the extent to which they might be at risk for ongoing violence in their lives or the impacts of violence, whether it be historical or ongoing. The other thing that, for teaching nursing and nursing students, that I think is really important is that practicing from a trauma and violence informed care perspective or practice perspective, you don't have to be a violence expert or a trauma expert. Good practice, careful practice, listening, being supportive is really really an adequate first-line response to violence and experiences of trauma. So I'm just going to sort of, to summarize, go through the principles, and this comes initially from the BC Trauma-Informed Practice Guide, the principles that are very common related to trauma-informed practice and suggest how adding violence into the mix would perhaps enhance it. So I've sort of highlighted in red what addressing violence would add. So the first principle, of course, is awareness. So in addition to thinking about the high levels of trauma across the lifespan, thinking about the high levels of ongoing violence that people are experiencing. And then really looking at not just the significance of historical experiences at the individual level, but also at the collective level. And of course, most recently, this has come to Canadian attention in relation to residential schools, but there are many other sources of collective historical violence. I think we are increasingly dealing with the consequences of people's experiences of being refugees, living in very high conflict areas. People have experienced in other institutions high levels of violence. So I think it's beyond the important example of residential school in many other contexts. The other thing is that when we pay attention to violence, I think it really enhances our ability to understand and respond to people's substance use issues, particularly if we understand that people are often experiencing ongoing forms of violence, such as racism. So when that just sort of extends when we're talking to we're serving people who have histories of trauma. Trauma-informed practice draws attention to unsafe relationships, but it doesn't necessarily help us to pay attention to unsafe conditions that people are living in, and our responsibility as service providers to try to intervene at organizational and policy levels. So when we look at the second sort of key principle of trauma-informed practice, the emphasis on safety, then this suggests that we should add the idea of cultural safety, which is what I suggested at the beginning. I don't think we can have trauma and violence-informed practice without really trying to orient ourselves to cultural safety. So cultural safety, as many of you will know, means shifting from focusing on the presumed ethnicity or race of the individual we're serving to really paying attention to the culture of the services we're providing. Okay, so just to carry on with that idea, I think that this is, we do talk about secondary trauma for service providers, but I think that it's really important that we be very explicit about providers' experiences of interpersonal and structural violence. And, recently we just finished this intervention study that I mentioned where nurses were working in nurses and Indigenous elders were working with women who'd experienced violence to try to really enhance their health. And it was really difficult for Indigenous care providers to sort of live again through some of the women's experiences. And many of the providers, and people who work in the violence sector will know this, many providers or service providers have their own histories of violence, and yet we provide very limited support for service providers, and I think that's an area we could do a lot better in. We've recently partnered with primary care clinics who are in non-profit, run by non-profit organizations, and the care providers are serving some of the most highly marginalized people and with horrendous histories of violence, and yet they have really no employee assistance programs, for example. So that's another area in which I think this idea of trauma and violence-informed practice can really turn our attention more explicitly. So the third sort of key principle being enhancing choice, collaboration, and connection really would be enhanced by legitimizing our responsibility for structural change, and depends on what sector you're working in, but when you're say a nurse working in a mental health clinic, you're not paying as much attention to policies and how clinics are organized or how funding operates, and it's not necessarily seen to be a legitimate part of your work. But I think we could do more to legitimize that and really say that all of us as service providers in our various sectors have a legitimate role in advocating for structural change to better support not just individuals, but our clients as a whole. Finally, this idea of really building on strengths and taking a strengths-based approach. When we think about violence, integrating attention to violence and structural violence as ongoing, then it helps us really pay attention to historical violence. So we're not just dealing with the immediate problem in front of us, but taking seriously the impact of collective and individual histories. So when we turn our attention to practice, then how does it look different? My examples are from the healthcare setting, but I think those of you who are from other sectors might have good examples as well. But this is just an example of what happens. Often, a person goes to emergency frequently with some vague complaint, and this is very, very common. A person has, we know chronic pain is associated with violence, and when you have a history of intimate partner violence over a period of time, chronic pain is very common, not just directly from injuries, but from chronic stress, and we know that, and yet often what happens is people are thought to be drug-seeking. And, you know, rather than thinking of people as drug-seeking, I hope we could shift to thinking about people seeking relief from pain, because we've had quite a bit of beginning success with offering people other options other than pharmacological options for pain management. But typically what happens is there's an assumption in healthcare settings that people are drug-seeking, and they're simply redirected to primary care providers, and often people don't have access to primary care providers, as you might know. Under a trauma and violence informed practice approach, we would spend some time asking about what the person thinks is going on for them, thinking about how their pain might be connected to their history, acknowledging and validating, and then discussing some alternatives. And again, this is an area certainly that the healthcare system could do a lot better job of, is actually providing some tools to providers for alternatives to pain management other than narcotics. Another example, again, sort of from the healthcare system, we often are frustrated with patients when they don't comply with whatever it is that the healthcare system thinks they ought to do. And there's some pretty punitive responses to things such as missed appointments or the inability to get appointments and so on. And yet, if we were practicing from a trauma and violence informed perspective, we would take a somewhat different approach. We would pay attention when people are missing appointments, when they're having difficulties getting there, when they're fearful of certain, or they're avoiding certain diagnostic procedures or even treatments. We don't necessarily take into account that there might be a history of violence and trauma. And we are, I think, less effective than we could be in helping people to manage just even the stress and challenge of coming for services. We forget, I think, on the service provision side, how anxiety-provoking it is to go into a police station or to go to an emergency unit. And we could be, I think, better at helping people to manage their reactions to being in places where they might anticipate being disempowered. So just to give you, just draw attention to some of the ways in which structural violence gets enacted particularly in healthcare, and this is, you will recognize perhaps Mr. Brian Sinclair, who died in a Winnipeg emergency waiting room and wasn't recognized to have died for 48 hours, and yet the staff said that they treat everyone the same, that discrimination didn't have any role in his death. So I think this is an example, and unfortunately we have examples of Indigenous people being poorly treated almost weekly in our media in Canada, and yet we don't have very good collective responses to that. So this is just a bit of an example. So some of the ways that we've tried to take this trauma and violence informed care into actual practice settings is at a policy level. And the gentleman that you see in the foreground there were receiving care at a primary care clinic, and one of the things that was very distressing to the patients was that they had to line up outside the door in the rain for usually an hour or so in the morning in order to get an appointment. And this had been going on for quite a while, and it wasn't just that they had to line up in the rain. It was that passers-by were often very demeaning. They were often at the mercy of drug dealers who were encouraging them to go in and get certain prescriptions. Some of the women were experiencing quite violating sort of actions by other people, and yet the organization was able to solve this problem once we sort of brought it to their attention by just changing their policies, their lineup policies, and how people got appointments. So just an example of when you pay attention to the circumstances of people's ongoing, their daily lives, care can be shifted in important ways for everybody, not just for select individuals. So finally, I just wanted to, if you haven't heard of the idea of structural competence, I wanted to sort of offer that idea. These folks by the name of Netzel and Hansen have built on the idea of structural violence to say that we need to develop in our services structural competence, and that means beginning with paying attention to how structures shape our service provider interactions. So, you know, how our services are organized, how we're funded, our policies, they really shape how we interact with one another. We want to develop, I should probably say, for those of you who aren't in healthcare, an extra service language of structures. So really drawing attention to structures all the time. So making explicit how people's housing challenges, food insecurity, employment difficulties, the racism they experience, how that impacts on how they respond to service provision. Maybe people are anxious, afraid, suspicious, angry, those kinds of things. There's reasons for it, so drawing attention to that all the time. Thirdly, rather than sort of explaining things as cultural, trying to shift that understanding to a more structural understanding. And I'll just give you an example. We know that if you have signs in the language that people speak, or you have art that people recognize as being familiar to them, it makes people feel welcome. But it's not just a matter of sticking words up on a wall or putting art on a wall, but rather engaging in a process with communities to have a more welcoming environment that's collective and tailored to the context of the people that you're serving. Fourthly, to really try to come up with structural interventions. So not just interventions that are aimed at individuals, but how we can do a better job of our policies, whether or not we can have a different way of talking about people, for example, in staff meetings. So I certainly know that in healthcare we get pretty objectifying of people and use lots of labels, and yet we've seen when we work with primary care clinics that when people are paying attention to structures and ongoing structural violence, they can be much more humanizing in the way that they're talking about patients and clients, and that more humanized way of talking about people leads to a deeper understanding, and that spills over into the client-provider interaction. And finally, this idea of structural humility, and that means admitting to ourselves that we can't fix it all, because often, I know in the work that I've done, nurses get very overwhelmed with the conditions of people's lives, and they feel almost powerless because they can't fix people's poverty and they can't fix the violence that's ongoing in people's lives. So mental enhancement are suggesting that we have to be a bit humble about it and understand that we can only be a small drop in the bucket, but that together, if we're all little drops, that it hopefully will add up to something. So a couple of practical strategies that you might find interesting. A trauma walkthrough is something that's been long kind of recognized and recommended for creating a trauma-informed organization. But we take this idea of structural violence, then what you want to do is a trauma and cultural safety walkthrough. So it's very similar, but a bit more expanded beyond what you would do if you did a trauma walkthrough. Walking through your organization and asking questions about where clients could be made to feel more safe, how safety and welcome are promoted, and so on. I've been walking around with a camera taking pictures of welcome signs. So welcome signs often say, violent behavior, abusive behavior will not be tolerated, or you'll lose your appointment if you don't check in. And so we could make our spaces and our approaches, I think, a lot more both trauma and culturally informed. So we've been creating all kinds of tools for people, and if any of you are interested, you could just contact me and I'll direct you to some tools for doing those cultural safety and trauma-informed walkthroughs and other sort of point-of-care tools that we've been trying to work on. But here are some of the questions that I thought I'd throw out to you, and I'm hoping you're going to have discussion and questions yourself, but these are just some of the questions that I wondered if you might consider. What about your workplace? What are things that work against implementing a trauma-informed, trauma and violence-informed practice approach? What ideas in your workplace support it or work against it? Where do you see the effects of violence showing up in your practice? Who would this be most helpful for? And do you have any thoughts around what you might do? Now, I've talked rapidly for 52 minutes, and I'm going to see if any of you are going to respond and offer me some comments, questions. Hopefully somebody heard me. How do you balance the need for creating a welcoming workplace and also protecting staff from violence in terms of welcome signs? Yes, what an excellent. And thank you, Leah, for saying we heard you. Thank you. That is just such an excellent question. How do you balance? I think that's very context dependent. And again, I'm thinking that many of you would have thoughts on that, but I'm just going to offer one set of examples. Often emergency units have security staff, and they're usually big, burly guys in uniforms. And clinics often have those, and they sometimes have bars and cages. And in two examples, one at Central Interior Native Health in Prince George, they decided to do away with the bars and with the uniforms, and they went to a much more open area, and they integrated elders into their waiting room. And the shift has been remarkable. It's a much calmer place. There's much less of any kind of disruptive behavior, and in fact, I think patients themselves got to participate in helping one another not to engage in abusive or difficult behavior. Another example would be Surrey Memorial Hospital. They've also just shifted from, and we'll see, they're pretty pleased to date, I think. They've shifted from having security guards man their emergency unit to having the same people but in a less sort of military-looking uniform, going around and being much more proactive in greeting people, making eye contact, welcoming people, seeing how they're doing, and that really seems to be making a big impact. Now, I don't know, Linda or Sarah, how do I sort out, do I just read these? I have Michael.
Colleen, Dr. Varcoe, if we've got some questions here, if we could present those to you. Oh, great, and then we'll just do them one at a time, and you respond, and then we'll do another one.
All right.
Does that sound good? Okay.
Sounds great.
All right. One of the ones that, there's a number of them, and I'm just looking, but one of the ones that, how can we help to build awareness of trauma, violence-informed care among family court professionals within the family court system, which is a big part of structural violence?
Well, I think you better get an expert on the family court system to help us with that question. I don't know that system well enough. I've only worked with family court workers, and I think that they themselves sometimes feel quite marginalized within that system. So I don't have any, I am imagining that people that are participating would have better answers than I, but it strikes me that we need to have organizations that are supportive, and that it needs to be both a bottom up and a top down. So I know that's not a very good answer, but I don't think I have that expertise.
Here's another question. Are there examples of policies that are open and can be shared for other organizations to integrate and apply?
Yes, I definitely think there are, and I think, I mean, there's policies from intake policies to policies about frontline staff. I'm really interested in the fact that we keep educating people, but it doesn't necessarily translate into behavior change. So I think the question of policy is really important. And again, I'm sorry I have to draw on healthcare examples, but you know, for example, one of the hospitals we're working with really wants to improve how people are treated when they're greeted at the triage desk. And rather than relying just on training and hoping that the staff will have a welcoming, empathetic response to people, they're going to sort of set some standards and give them some scripts that says you won't say this and you will say that. So I think that the idea of policy is very important. And yes, there are a range of policies for different contexts that I think are shareable. And I think we have a lot of possibilities for sharing between different sectors. So, for example, in the shelter sector, there are some really good policies around how to manage people who are substance using, so that they aren't disrupting other people and yet are kept safe and are able to access services themselves. So I think the answer is yes.
Dr. Varcoe, here's another really interesting question. They all are, but this one is, in assessing trauma violence-informed care through walks, have you experienced contradictory feedback on how to adjust the response based on differences between populations served, such as age, gender, cultural history, etc.? And if you did or know of such contradictions and challenges, how were they resolved?
Mm-hmm. Yes, I think there are. I mean, there are contradictions at all levels. I mean, there's even contradictions in our goals. So, you know, we have limited services, and we have to serve a certain number of people over a certain time frame, and sometimes that feels like it's at odds with providing a more trauma and violence informed care approach. And you know, often care or service providers say, well, we don't have the time. My argument is it doesn't take any more time. So it doesn't take any more time to say, oh, it's really nice to see you back, versus you're here again. So I think that we do have contradictions, but often we get a bit entrenched in our positions and don't look for ways of upholding all our values. That is to say, if we value efficiency, but we also value dignity and respect, are there ways in which we can approach them at the same time? Having said that, the other part of that question is, there are different needs for different populations. And you know, a simple example is when you have a setting where there's children involved, and adults and children, and you know, if you have, say, primary care settings that we've worked in, you know, there are adults who are using substances, or drinking or whatever, and you want to be able to provide service to them, but you also want to make sure that the space is safe for children. So not everywhere can have a separate space. So how do you can try to do that, or you don't necessarily have to have a physically separate space, but maybe aiming to cater to those whose needs are greatest. For example, aiming to keep, if there's children involved, keep the children safe as the first line priority. So I mean, it definitely, there are definitely contradictions in terms of who's being served and whose needs are greatest. But I think that if we take contextually tailored kind of approach and try to uphold as many values as possible at the same time, that's part of a step in the right direction. But there's no question that that there are those kinds of contradictions, and we have to continuously work through them. And sometimes the process of working through them is where you come out with some of the best outcomes, at least in my experience.
Another question that has come in is a comment and a question. The comment is, I think there is still a lot of minimization and denial of the fact that racism is a form of ongoing violence. Are there ways you've seen that we can use to communicate this concept in an effective way?
Yeah, I've spent probably the last 20 years trying to learn how to deal with racism, prevent racism in a way that doesn't get people's backs up. And I don't know if this is a bit tangential to the question, but one of the things that I think is really important is this idea of drawing attention not to how we are individually socially located. None of us are responsible for the amount of pigment we've got in our skin, but we are responsible for how we behave. So when I'm working with nursing students or medical students, I'm asking them first to begin not with their own positionality, but with how they are taught to think about race and racism and ethnicity and culture, how they're taught to think about how we're positioned advantageously and disadvantageously, and beginning there. So I think for me the first step is enlisting everybody in the effort to address racism and get rid of it for once and for all. It's a tall order in this world today. And beginning with not getting people in defense who have privilege, not getting them into defensive positions. So the fact of having the privileges, the unearned privileges that come with white skin, it's not your fault. And what you're responsible for is what you do with that privilege, how you use it. I found that to be one of the most successful things, because then we can all sort of try to get on the same page. And I also find that helping people to see the parallels between multiple forms of disadvantage is helpful. So I start now with the issue of gender and helping students to think about the diversity of genders, think about being beyond or understanding beyond the binary of male and female, and then try to translate that into dealing with racism and other forms of stigma and discrimination. That's a mouthful.
I think that was certainly helpful to me, and I'm sure to many of our participants as well, Dr. Varcoe. Another question that's come in is a little bit, taking us in a little bit different direction. And the question is, what impact do you think having more services available to support men would have on the level of violence? For example, more men's support groups, more proactive education programs, etc.
Right. So I don't want to conflate men with perpetrators, because as I said, I think there aren't really hard and fast lines. I think that we know that women experience the greatest burden of intimate partner violence globally, but we also know that men experience the highest victimization, mostly of other men's violence, but not exclusively. And we're only, I'm a old school feminist, but I really have to pay attention to men's experiences and boys' experiences of violence and how we're raising and treating our boys and men. Working with indigenous communities, the question has always been, what about the man? And so to back up, I think that if we're thinking about men who are perpetrators of violence, then we have very limited evidence in terms of what actually works with men, what actually supports men to be less violent. We've just at a national level been looking at this, and we don't really have good, strong, clear direction on that. At the same time, what we do know is to whatever extent we can work against the notions of male superiority, and to whatever extent we can work toward gender equity, we're going to reduce violence and violence against women. So to return to the question, I think a whole lot more support for men in a variety of ways, and not necessarily men as perpetrators, but men as healthy members of society is really important. And I'm going to give an example. The Vancouver Native Health in Vancouver, in British Columbia, the men saw that the women were having women-specific programs, and they said, hey, what about us? And so they created the Dudes Club. And the Dudes Club didn't start focusing on men's experiences of violence and victimization and so on. It started on men's health. And it's been absolutely remarkable. Every 2 weeks, about 70 men to get together, and they talk about their health and their loneliness, and they have talks from physicians, and the favorite topic is bones and boners, which is talking about men's sexuality and men's osteoporosis, and it really has created a much healthier community. And when you talk to the men, they've really taken a lot of way in terms of understanding women's experiences and being able to take a much more respectful stance. So I think there's an incredible amount of potential in that direction. And thank you for that question.
It's interesting, while you were answering, Dr. Varcoe, another participant just wrote in that because of the number of men who had experienced victimization coming forward, they've actually changed the signage on their organization. So that was just really fit with what you were saying.
Excellent example.
Yeah. One question that again moves us in a different direction. One of the participants was curious about your reference to grounding exercises and wondered if you'd be able to describe some of those or one, or give some references or a reference. And we're happy to do that after the webinar and send it to everyone if that's your preference with references. But if you would speak to an example or bring that to life a little bit for participants, that would be helpful.
Right, yeah, thank you for that. I just wanted to go back to the changing the signage. I think that's a really good example of where, you know, the collective, the organizational policy kind of interventions can really have an impact in making people feel welcome and anticipate that they're going to be treated well. So, yeah, so grounding exercises. And, you know, I think that these are things that can be as simple as helping people. As a nurse, I'm always trying to help people live through pain and focus. And it can be as something as simple as, you know, okay, look at me. I'm going to hold your hand. Is that okay? Or it can be encouraging somebody to take a deep breath. It can be much more focused than that. And the team that I work with in testing out this online health and safety, it was started out as a decision aid for women who experiencing violence, but it morphed into more of a health and safety planning online resource. And in it, as people were working through the online platform, we put a lot of those kind of grounding exercises that people could choose to do or not choose to do. And it depends on, I guess, on the individual, because some people it's fine to say, okay, take a deep breath and, you know, maybe close your eyes. That's a safe thing to do. For some people, that can be quite intimidating and quite frightening. So I think you have to use grounding exercises and there are some very explicit ones that are guided imagery, that kind of thing. I think you have to always use them, optimizing the choice for whoever you're working with. And you know, some of us were at a Traumainformed yoga session when the Knowledge Hub had a session in Vancouver, and I thought it was really interesting the extent to which they were non-invasive. And so they constantly were saying, if it feels okay to you, why don't you try this? Very invitational, very non-directional, no commands, and no insisting that people do it. So having said all those cautions, I think there are a number of things. You can suggest people simply to put their feet on the floor and to sort of just feel the floor through your feet. Helping people to stay in the moment, stay present, to control their breathing, to stay focused. Those kinds of things are often part of grounding exercises, and I can certainly share some references if people are interested.
I think at this time we really need to draw our time together to close. I just wanted to remind people that before I thank Dr. Varcoe, that The slides will be available on the website following this presentation, and we really appreciate that, Dr. Varcoe, because people often want to refer back and to not be taking notes while they're listening during a webinar. So that is really an advantage for all of us. And there are some additional slides that Dr. Varcoe has in her slide deck that have some really concrete things you can do in your settings and to think about and adapt which ones would fit, which wouldn't. So that will be in the slide deck too. So, and just before we do our thank yous, please look for the link to do an evaluation, because we want to continue as the Knowledge Hub and Learning Network to bring you webinars, and your feedback and input is very helpful. But in terms of our conclusion, Dr. Colleen Varcoe, we were thrilled here at the center, all of us sitting and listening, and we really hope that the participants were too. And their questions suggest that you really were making us think, and to not just think in a theoretical way, but by the nature of the questions, to really translate, well, if given you're raising this, what does that really mean in terms of my setting? And what might that look like? And what are some ideas for really moving forward? So I can't imagine what it's like in Geneva right now, Dr. Varcoe, but we're certainly happy that you found a way to be with us in Canada and beyond for this particular webinar. And we certainly look forward to more communications with you in the future.
Thank you very much for having me, Linda. And it's Colleen, by the way.
Thank you. And with that, okay, enjoy the rest of your time in Switzerland. And to our, and to the participants, again, please fill out the evaluation, and it really helps us plan. And any feedback you have on the mechanics of the webinar as well, we appreciate that, and we give thought to that in terms of planning ahead. And just want to remind you that there was a question about policies, and the next webinar, Holly Murphy will be joining us, and I think that we'll learn more about how to implement a trauma-informed violence approach in organizations and the actual concrete steps and lessons learned. So we hope you'll join us for that as well. And with that, we'll sign off. Thank you to everyone.